So I think I've done an introduction already. A few people have joined again. So this is just a CCA finals quick summary PowerPoint, essentially based on cardiorespiratory. Essentially, we'll be going through taking the cardiovascular respiratory history, which I'm assuming everybody is very familiar with, especially to the run up to exams, just reviewing the examinations, going through history taking, a little bit of clinical reasoning like chest x-ray interpretations, ABGs and ECGs, I believe. So, history taking, I'm not going to go into too much detail on this essentially. We know how to take a history. So starting with your presenting complaint all the way up to your social history. It's quite important. In final years, I would just say pick up on the cues that the patient is giving you. Start off with basically the most open question you can start off with. Just ask them what they've come in with or why they've come into wherever the scenario is, hospital, GP. Let them give you their opening statement. Follow the structure, obviously. If you're stuck as well, if you have no idea what's going on, most of the time, if you just go through the entire structure, you're able to pick up on cues and figure out what's going on, essentially. If it's pain, go through Socrates. We all know Socrates. ICE is a big thing in Manchester final CCAs. They love ICE. Go through your ideas, ask them what they think it is, get through their concerns and get through their expectations as well. Again, pick up on cues, red flags, summarize signpost, and always acknowledge emotions. I think the biggest thing with CCAs is time management most of the time. It's quite difficult, especially if they're giving you quite a big history or it's quite an emotional history. Just always trying to be on top of time management as well, especially if there's like a 6-minute timer and they're going to ask you questions in the last 2 minutes. I would say the biggest thing is, especially if, just to cover everything, is do a quick systematic review at the end as well if you have time. Go through systematic signs like obviously fevers, weight loss, weight gain. Some are not as relevant, but I would always just go like top to bottom. Have you got a headache? Any vision blurring? Chest pain essentially is a good one. Always ask about changes in bowel habits. What else is there? How their waterworks are doing. Just a quick systematic review is always good, and it sometimes brings out things that they would have forgotten to mention or they've not given you because you've not picked up on the cue essentially. These are some example stations that I thought were relevant for cardiorespiratory topic. Some of them are past Manchester final year stations as well, so some of them could have been actual just history taking, some were combined stations like history taking and examinations, and some are always combined with like communication skills. Explain this condition, explain this drug, for example. So a lot of common presenting complaints in this topic tend to be pain, whether it's chest pain or pain anywhere else. Shortness of breath is a common one, and cough is a big one. I think the rest tends to be associated symptoms, but they can also be common presenting complaints as well. And these are your common differentials to do with those common presenting complaints. So we have 3 scenarios. I'm not sure how this would work. I was thinking about running through one scenario together as a group, essentially, and seeing if we have volunteers for the second or third, or we can put people into groups, but I'm not sure the logistics on that. And I'm not sure how interactive people want this to be. So we'll work through the first one as a group, if that's okay. So the first scenario is a 47-year-old female presenting with chest pain, essentially. Is there any takers on what questions should be asked next, or how they would elicit a history from just a chest pain, essentially?
If for scenario 1, guys, if we pop things in the chat, and then for the later scenarios, I'm probably going to use random allocation of breakout rooms, and I can actually split people off into like pairs or 3s, I'm pretty sure, and it'll just split the entire room and you'll all go and do it with someone random, so you get like the OSCE nerves and stuff. But for now, if you just pop in the chat, then it'll be grand. Can you see the chat, Ziqra?
I can see? Yes, I can see it. Let's have a look. Perfect. I'm seeing a bunch of Socrates. Yep, associated symptoms like shortness of breath, syncope, edema. Perfect. Good. Let me just... Sorry, I'm navigating this on the website, not the app. I think that's why I'm struggling a little.
Oh, I see.
Okay, there we go. Perfect. Yeah, Socrates, associated symptoms. Perfect. So essentially, in this scenario, if there was an actor, the way I scripted it was, yeah, I've had this chest pain since this morning. They're finding it quite difficult to catch their breaths. So this is the history of the presenting complaint, and a lot of you said Socrates. So essentially, the onset was sudden in the morning. They walk into the bathroom. It's a sharp stabbing in nature. It's central sided. It's not radiating anywhere. If you would ask for a score out of 10, they would have said 8. And it's worse on breathing in, and it's worse with a deep inspiration and when they're coughing, and nothing has made it feel better, essentially. So what are people thinking based on that Socrates? Yeah, Lydia said PE.
Pericarditis.
Pericarditis, yeah, could be. Any other thoughts? Those were good thoughts. I think both are quite good. The cough worse with deep inspiration and coughing sounds quite pleuritic in nature, doesn't it? After your history of presenting complaint, I think someone's already mentioned this. You can go on to associated symptoms, can't you? Oh, sorry. Oh, they were finding it difficult to catch their breath as well. So I would break things up, chunk it up. So chest pain first, shortness of breath, started at the same time. It's worse on exertion. So they were walking to the bathroom, weren't they? They've not experienced a wheeze apparently, and they've not had previous similar episodes. So if we move on, now it's associated symptoms. There's a dry, mild cough. It's not productive. They've not noticed any sputum, no hemoptysis, no fever, but they've had calf pain for a few days now, and I've bracketed the fact that it's unilateral. So now I think it's pointing towards one thing, which someone has already said. What kind of questions would you ask if they've told you that they've got calf pain in one leg only? So I think the main thing here would be, it would probably point you towards what have they been doing? Is there any associated risk factors for what people have said already? So someone's mentioned PE. So are there risk factors? Can anyone tell me any risk factors for PE?
I think a lot of people have been mentioning long haul travel, recent immobilizations, for example, from surgeries. I think other people are trying to elicit like a Wells score, talking about differences in calf size, tenderness, redness, heat, history of COCP use.
Perfect. Sorry, I can't see those messages. I can only see the last ones from 6 o'clock, 6:17.
Okay. That's
but perfect. That's great, guys. So yeah, so the main thing here that they would have elicited apparently is a travel history. They returned from a long haul flight with minimal movement. They probably weren't wearing any compression socks, as most of us do not do on flights. And then we go on to the rest of the history. So past medical history, this person had pretty much nil. Drug history, they're on the combined pill, which is a good thing to elicit because it's a risk factor as well. They didn't really have any relevant family history. They're a non-smoker, drinks alcohol socially, and they work a minimal movement job as well. It's an office job. Okay, so I think most of us know what our top differentials are, but can someone give us a list of top differentials and other differentials that you would mention if they asked you what your top 3 differentials were, for example?
If we can say put a minimum of 3 before you send your message as well. So you send your differentials instead of one by one. Thank you, Netta.
You may have to read these out to me, Charlotte. Sorry, I can't see any of them.
Of course, I'll let a few trickle through just in case people are thinking about it. But we've got a couple of answers already.
Good.
I'll wait till 1822 and then I'll read them out. Keep them coming, guys. Nice, we've got a good list. Okay, so we've got angina or maybe a myocardial infarction, so ACS. We've got pneumothorax, pneumonia, costochondritis, pericarditis, but of course, in the mix is PE.
Good. That is a very good list of differentials. So I think the top one for everyone would be a PE. Others that would be relevant to mention, obviously you can mention as many as you want, but most of the time they restrict it to what are your top 3 differentials, and you say what's your most, and then you list a reason why you think the others. ACS, I think someone said that. It's less likely. It sounds like it's pleuritic, isn't it? It was worse on deep inspiration and coughing, and the long haul travel was more of a risk factor, pointing towards PE. Could say pneumonia. They had a cough. It wasn't productive in nature. They didn't have any fever or anything like that. Could be a pneumothorax, MSK pain. Oh, sorry, I've gone. And most of the others that were mentioned were perfect as well. I think I've only put a very bare minimum list together. So your guys' differentials have been a lot better. What would people's next steps be if this was a question in your history taking station?
When we've been teaching this year in our sort of MLA series, we've been using the HEBI model, and I know people from other unis haven't seen that. It's just if people want to structure their answer in the chat as history exam, bedside bloods investigations, that would be swell for next steps. Just something a nice F2 taught me that we're spreading the love of.
That's quite good, yeah. I think I always went bedside, yeah, and then investigation. I didn't really have much of a structure as a final year medic, no.
I've just never heard it as HEBI, and it's just nice to remember, isn't it?
Good one, yeah. Oh, what's happened? Oh, there we go.
Okay, so we've done the history, we've asked more specific questions, and then people are saying, let's do a cardiorespiratory exam, bedside, basic obs, so SATs, and we've even had someone say do an A to E. And then furthermore at the bedside, you can do the ECG, and then think about a chest X-ray. We've got a query as well of considering a Pixaban. I think that falls more into like management steps.
Yeah. Good. I agree, actually. So start with observations, definitely do an examination. You could do an ECG, chest X-ray, exclude your other differentials, so pneumonia, pneumothorax, ECG for any of your heart causes like ACS, any strains essentially. Bloods. So it's a PE, or if we do a well score and it was quite low, which it wouldn't be for this case, you would consider a D-dimer. But do your routine bloods as well, your FBCs, USANEs, do a coag screen. If you're trying to rule out ACS, you could always mention that you want a troponin as well. Doesn't really, I don't think it's necessarily needed, but if you're trying, it's always justifiable if you say you want to rule out ACS as a cause. I'm not sure if anyone mentioned definitive imaging, but if we think it's high chance of a PE, CTPA is always your definitive imaging. And if that's contraindicated, for example, renal impairment, pregnancy, you do a VQ scan instead. What was the question? Sorry, Apixaban. Apixaban would fall into management, yes. When would you go straight into managing a PE without getting definitive imaging? Or like giving them treatment dose cover?
Sure.
Sorry, say that again, you cut off.
I think they can't say it again, but most people have said considerable delay if they're hypotensive, massive PE.
Perfect, yeah. So this would all be if they're hemodynamically stable, first of all. Again, if there's considerable delay getting any of your blood tests, any of your imaging, always cover them first, treat them, and then we can always step that down, can't we, if imaging proves to be negative. Good. And then, yes, I have included your DOAC. So CTPA positive or delay, go straight onto a DOAC. If it's negative, and this person in this history had calf swelling, didn't they, unilateral especially, so we would always consider a proximal legs ultrasound scan just to rule out a DVT as well, if it hasn't spread to PE. I think I've added just a little bit on a Wells score. Yep, so you could always mention Wells scoring as part of your next step as well. You don't have to mention all the clinical features, but you could mention that you would do a Wells score. If it's more than 4 points, it's quite likely to be a PE. So you would go on to definitive imaging like CTPA or VQ scan. If it's less likely, you're more likely to do a D-dimer. And if that's positive, you would then do a CTPA essentially. And I think these risk factors, a lot of you have mentioned already. I think I heard immobilization for a long time, long haul travel, it counts as that. Again, clinical signs and symptoms of DVT, which we had unilateral calf swelling as. Any previous history from this one, there was no previous family history or personal history either. Hemoptysis is a big sign. And any type of malignancy within the last 6 months or currently they're being treated for cancer would count as well. Okay, has anyone got any questions on that particular first scenario? It's either people are wanting to practice them in the group itself, or we can move out into breakout rooms and people can just practice them. Are we able to do the randomized breakout room?
Yeah, I can do.
Thank you, Charlotte.
Are we doing?
Click through them for me. So
Yeah.
thank you guys
You just
for
let me
having
know.
a go at scenarios. Yeah, perfect. Scenario 2 and 3 sorry, we weren't able to come into every breakout room, just technical difficulties, but from the end of what we were hearing, there were very good discussions going on. So this was the first scenario that we've already gone through. So if we just click through these ones.
Sorry about that, guys. Just had to mute someone doing their hoovering.
So your second scenario was, so you've all probably had a read of the script anyways, but it was a 56-year-old male with breathlessness, and the history of the presenting complaint was that they were getting short of breath over the last few months. It was gradual. They're walking a lot less than they used to, 50 meters. They need more pillows essentially, and they wake up gasping for air essentially. So if we carry on, we had a few associated symptoms as well. I'm not sure if we got through all of them just because of the 6-minute time limit, but if you were to elicit them all, you would have heard weight gain at over 4 kilos, mild chest pain, but it was only on exertion, relieved by rest, reduced exercise tolerance, fever, cough, a bit of ankle swelling as well. So these were the past medical histories if you guys got onto it. Hypertension, previous MI, they should have had type 2 diabetes as well. They had a family history, I think, if we just load all this up, drug history, family, social. Yep, so they were on blood pressure meds, they should have been on metformin. Family history, if you did elicit, was their dad died of a heart attack, and if you iced it, they would have been a bit upset over it and concerned about it. They were an ex-smoker and drank 10 units a week, but live alone. And if you did a quick systems review, no syncope, no chest pain, no hemoptysis, and no to everything else that you would have asked essentially. So what were people's top differentials when they were thinking about this scenario? If you put them in the chat, we can then just quickly go through them. Good, yeah. Heart failure, angina. Can't think of it. Yeah, that's fine. Anyone else? It is a very heart-sounding history, isn't it? So, Heart, ACS, COPD. Could be dilated cardiomyopathy, someone's put. Good. Yeah. What are people's top differentials? I think 2 of you have put it as your top ones anyway, haven't you? Yeah. CHF. Should we load up the top differentials? So yes, so chronic heart failure they were describing orthopnea, PND, they had cardiovascular risk factors. It was a gradual progression as well. I think the key was they were gasping for breath when they were waking up. They couldn't lay flat when they were sleeping, essentially. And other differentials, you've had quite a good list as well. ACS is a good one, COPD. I was just trying to go out of the heart stuff just to give you some varied history differentials, but COPD, interstitial lung disease, PF, anemia is always one, just shortness of breath. It's not the top one, obviously, and any type of valvular heart disease as well. And your heart, if you had acute heart failure, it could be secondary to your valvular heart disease as well. So that could be a good differential. What would people's next step be? So it'll be very similar to the last scenario, just, yep, good chest x-ray, someone's put. ECG, cardio exam, perfect. Good, bedside cardio exam. Anything specific if we're thinking chronic heart failure? Good, BMP, perfect. Good, shall we load the next steps up? Good, TTE, referral for echo, perfect, that's what I was looking for. Good, so always do your bedside OBS examination, do their fluid status. If they're really unstable and you're worried, always mention you're going to get a senior review. You can never go wrong in a CCA or OSCE if you mention senior review. Do your basic bloods, FBC user-Nes, LFTs, thyroids. BMP is the big one. You want to see how high it is. And then if you want to do some cardiac imaging or cardiac related investigations, get an ECG, get a chest x-ray. If it's a PA film, you can also assess for cardiomegaly, can't you? You can see if there's any pulmonary edema, get an echocardiogram. That's your main gold standard here, isn't it? You can see the ejection fracture, see if there's any valve disease, structural abnormality that could be resulting in heart failure, essentially. Good, I think that was a good scenario. If we go through the third one, or the second one for you guys. So the presenting complaint was a 67-year-old male with a cough. So it was a cough that just wouldn't go away. This would have been the history of presenting complaint. It would have been for 8 weeks or 2 months. It was dry, persistent, non-productive, a lot worse at night. And sometimes the key thing here was they would have noticed some small streaks of pink when they were coughing. They were quite breathless, had a chest pain that was achy, worse when breathing in. And if you did a quick systematic review, they would have experienced some weight loss, a bit of reduced appetite, fatigue, but no night sweats or fevers and no TB symptoms, essentially. So if we move on to past medical history, hypertension, COPD, they were on inhalers, amlodipine, I think I said ramipril to somebody, sorry, family history, social history, they were a 40-pack year smoker, and if you asked about their occupation, they did work in construction, and they may have mentioned that they had asbestos exposure. They're quite independent, they live with their spouse, they don't drink much at all. So what were people's top differentials and other differentials that they would have mentioned if this was an OSCE? Yeah, someone's put lung cancer, perfect, and that's the top one, isn't it? Good. Asbestos, bronchogenic cancer, mesothelioma, good. TB, good. Someone's put a list. Lung cancer, asbestosis, COPD, mesothelioma. These are very good differentials. Good. Someone's mentioned exacerbation of COPD. Good. Mesothelioma, lung cancer. Yep, we're getting a very good same history. Yep, idiopathic pulmonary fibrosis. Perfect, guys. So if we move on to the list that I've created, Not sure if I was as thorough as you guys, but yeah, so your cancer is your top one, isn't it? Mesothelioma is what I was going with, which I've not mentioned, which is not very good, but the big clue there was asbestos exposure, isn't it, if you had elicited it. However, the other clues, if you didn't directly ask for it, would have been the hemoptysis, and they lost a bit of weight as well, didn't they? And they've got this chronic cough that's not going away. So other differential, COPD exacerbation, which people have mentioned. Pneumonia is less likely, but it could always be up there. Interstitial lung disease, TB, good. A lot of people have mentioned this. This was just a random one, chronic rhinitis. It's not very chronic rhinitis sounding history, but if you want to go think outside the box, heart failure, could be just a post-infectious viral cough, you never know, but you have to rule everything else out, don't you? And P, but it's very, very unlikely, I think, in this one. Next steps, what would people do as a next step? Someone wants it so they can flick through the slide. I think that's how it was before. We can change it in a little while, sorry. Perfect. Resp exam, blood, 2-week wait referral, perfect. Chest x-ray, CT thorax, great. Resp exam, EP examination, look for clubbing, blood cultures, sputum cultures. 2-week wait, perfect. So if we go through the next steps, just I'm conscious of time, sorry guys. Observations, examinations, smoking cessation advice, which when we went through the history, which Charlotte, you did mention, didn't you? That was really good. And urgent chest x-ray, and then yes, 2-week wait for suspected lung cancer is your big go-to here. Perfect, guys. So if we just move on, I think the next slide is 2-week wait. When would you 2-week wait? Does anyone know the guidelines? Do you know what age you'd have to consider 2-week wait? +40, yeah, 40+ and 50+ non-smoker, 45, perfect. Is asbestosis the stage before? I will double check that and let you know, but I believe it can be different conditions, and when it progresses, it's mesothelioma, but I'll check and let you know for that. So 2-week wait, perfect. If we flick through this, yes, so 40 is the age limit there. 40 and unexplained hemoptysis, always 2-week wait them. And if you have chest x-ray findings that are very suggestive of lung cancer, you would 2-week wait them as well. You could offer an urgent chest x-ray. This is unlikely to come for the station, but if they've got 2 or more symptoms or ever smoked with one of these symptoms, cough, fatigue, shortness of breath, chest pain, weight loss, appetite loss, you could 2-week wait them. But I would always do a 2-week wait for anyone over the age of 50 with hemoptysis, and or if you get a combined station with chest x-ray findings, anything that would suggest lung cancer, you would 2-week wait them. So if we just move on, I think there's a bit of communication of 2-week wait, which could be a station. So with 2-week waits, the thing is, set the scene. So sometimes it's very clear early on that you're going to have to 2-week wait them, and the whole scenario would be you introducing it. So you just have to easily mention that some of the symptoms are concerning. Don't shy away from saying that you think it could be something more sinister, such as cancer. Try and introduce the fact that you're going to arrange an urgent referral for them to be seen by the specialist team. So in this case, it would be the respiratory team within 2 weeks. I would say reassure them. I think you could say the line, many people that are on this pathway turn out to not have cancer. They have non-cancerous causes, but we don't want to miss out anything important. And then explain the next step. So likely they'll have more scans, tests, blood tests, and then just give like a little information about what they should do. So they'll get a direct letter or text in 2 weeks. They should stay in the country, make sure that their address and details are up to date, and then obviously address some emotions, safety net them just in case before they get the 2-week wait anything happens. So if we move on. So we are quickly going to go through examination. I think examination is one that you just have to keep practicing through. So it'll just be a quick run through because of the time, sorry. So with your cardiovascular examination, with all examinations, we start with the inspection, don't we? So end of the bed, look at the surroundings, mention anything obvious that they would have kept in there. Start with your peripheries. Most of the time for year 5 OSCEs, they do a focused exam, so you don't have to mention everything. So just keep an eye out for anything that, if they've said, take a focus history for a PE, a pneumothorax, something like, for cardiovascular, for example, infective endocarditis, mention those signs specifically instead. But these are some potential. So nails, you could always look out for clubbing, check your temp, cap refill. For pulses, for cardiovascular, try do all the pulses, obviously, offer them. They might say don't do it. So radial pulse, radial delay, femoral, carotid, look at the face, look at the mouth, look for dentition, cyanosis. JVP is very important. So you estimate the height above the sternal angle. If it's over 4 centimeters, it's raised. And always do a quick inspection of the chest as well before you move on. Examinations always shorten time, so the more slick you can get them, the more quickly you can run through, essentially. These are just some quick signs that I just quickly found on the internet. And this is how you measure your JVP. Obviously, you can't formally measure it in an exam, but just have a quick look, see if it looks raised. Bed should be at 45-degree angle, remember. So if it's not, just make sure you put it up, or at least mention that you should assess this at 45 degrees. If we move on, if anyone has any questions, just please put it into the chat. I'm just running through just because of timing. Sorry, guys. Yeah, move on to your palpation. It's always inspection, palpation, auscultation, and then other examinations, isn't it? Other skills. So check for palpation. Check for thrill, sorry. Check over your valve areas. If it's palpable, it's technically classed as a grade 4 or plus murmur. Check your parasternal heave and then palpate your apex beat as well. Auscultate, I'm pretty sure we all know how to auscultate by now, but you have your 4 areas: aortic, pulmonary, tricuspid, mitral. So aortic, pulmonary, both in the second intercostal space, left and right, and then you've got your tricuspid, which tends to be lower left sternal edge, and then mitral tends to be where your apex beat is. If we just move on for maneuvers. So when you're auscultating, and if you hear a murmur, for example, I would always palpate the carotid pulse. If you're struggling for the carotid pulse, go for radial, but if it's a CCA, just always palpate the carotid pulse, because that way you can then tell if it's systolic or diastolic. If you do hear a murmur, you can do your maneuvers. In an examination, if you've got time, I would just always do the dynamic maneuvers. It's a lot easier and it proves that you know what it is. So if you roll people onto their left side and get them to breathe in and breathe out on expiration, if someone has mitral stenosis, it will increase that. So remember, mitral stenosis, it will radiate to the axilla. Another maneuver is if you get them sitting forward and again breathing out, put your stethoscope on the lower left sternal edge of the tricuspid region. It will increase any radiation of aortic regurg, essentially. And then the rest of the cardiovascular exam is auscultate your carotid bruise, listen to your lung bases, and then always check for edema as well. Does anyone have any questions before we just quickly run through the RESP exam? Oh, sorry, there's a bit on murmurs as well. So just as a quick thing on murmurs, remember your S1 and S2, when you say you've got normal heart sounds, is your closure of your valves, isn't it? So S1 is after your atrioventricular valves close, S2 is after your semilunar valves close. So if you do hear a murmur, which is possible that they bring in people with actual signs, it's a turbulent blood flow. So that's why we get them to, we palpate the carotid pulse to see if it's systolic or diastolic. So if it's systolic, if it's on the pulse, essentially, if you hear the murmur, it should coincide with your carotid upstroke, essentially. So that's how you know it's systolic. You know, if it's after the pulse, it tends to be in diastole. So that's how you can tell the difference. Murmurs are just turbulent blood flows. So you have your usual ones. The most usual signs you'll get are probably an ejection systolic murmur, which is aortic stenosis, or you'll have your pansystolic murmur, which is your like whistling sound. and that tends to be mitral regurg if it's an exam scenario. The other ones you don't tend to hear, but you do have your diastolic murmurs, don't you? So you've got your early diastolic murmur, which tends to be aortic regurg, or mid to late diastolic murmur, which tends to be mitral stenosis. So most of the time, you could have a person with signs. Most of the time, it tends to be, okay, if in your questions, what are some signs of, for example, aortic stenosis? Where would it radiate? Things like that would be what you would get as questions. So make sure you know your murmurs, where they radiate to, where they would be best heard, essentially. Does anyone have any questions on that? Sorry, it was a quick run through just before I move on to RESP examinations. There were some new messages.
It's just someone asking if we can change the slides over to so they can flick through, but I think it would take a lot and it would disrupt the flow.
Sorry.
So.
Sorry about that. If we can, we'll change it through when we move on to another example scenario. If we run through respiratory exam, if no one has any questions. So again, same idea. You always inspect, you always palpate, you do the peripheries first. The extra things here would be look for tracheal tug, check for tracheal deviation, check your cricosternal distance. Lymph nodes, I would say do at the end, just because it takes time, and a RESP exam already is a very heavy, hefty exam. So if you miss it, you're not going to miss many marks if you miss a lymph node, whereas you'll miss most of the marks if you miss the rest of it, essentially. But if you do lymph nodes, make sure you've got your technique correct. You do the anterior posterior triangles first, supraclavicular, and then go for your axilla. And then again, always inspect your chest for your scars. For RESP, it could be just look for thoracotomy scars and things like that. Palpation, again, similar. This time you'd have to do chest expansion as well, parasternal heave. Percussion, which you don't tend to do in a cardio exam. It should be resonant, but if it's hyperresonant, could be some sort of air in there, so pneumothorax. Might be dull. It's less likely that you'll have signs for percussion on examination for final OSCEs. When you auscultate, mention what you can hear, so you can either hear normal breath sound, tell them if you hear anything reduced, crackles, wheeze. I think those are the main things there that can most likely hear. So just say no crackles, no wheeze, and normal breath sounds if it is that. And then repeat all on the back or front. I used to tend to start on the back and then move to the front. So I would palpate on the front and then do the lung, so auscultate and percuss on the back first and then move to the front, just because you're more likely to hear sounds on the back first. And then if you have time, you can then move back to the front, can't you? And then again, always check for edema. Again, sorry guys, that was a very quick run through. Has anyone got any questions? If not, I'll keep an eye on the chat and someone can tell me if I can't see the chat properly. But if we quickly move on to communication skills. So these stations, again, it's all combined stations for Manchester anyway. So the main things are figure out what the station is, essentially. So if it's explaining a condition, obtain a baseline of what they understand of the condition. If it's a drug, figure out what the drug is for, what they need to take it for. Explain to them in a very simple way how it works, how to take it. If it's a drug station, you'll have the BNF. So if you can't think of any side effects, come up with the basic ones, look at the BNF, or while you're speaking to them, I would always just open the BNF up so that you're not wasting any time. Find the right medication, and then when you get to your side effect part of the station, you have it ready for you to tell them, essentially. Always safety net as well. Chunk and check is the main thing. Always keep summarising and ask them if they understand. Not in a patronising way, but just make sure that they're understanding, and chunk and check as you go along. This one is, some people like to do this, draw diagrams and pictures. It's a very good way to get people to understand what's going on. Even if you're not the best artist, draw like a little squiggle and try to explain what you're trying. It helps a lot more than you think it does, even if you're a terrible drawer. And don't be afraid to use analogies if you have a good analogy in your head. So common station that tend to come up in final years for CardioRespiratory. There could be more, but this is just things that I thought of at the top of my head. Explaining AF is a good one. With that, you could get an AF and a DOAC combined station, and a Pixaban tends to be the most common. explaining hypercholesterolemia, explaining hypertension, and then the drugs that coincide with that. Ramipril tends to be a good one, statins, and the management for it as well. Explaining P, I think, has come up before, and then the fact that they need a DOAC. Remember, with Manchester, you can also get those difficult discharges and difficult scenarios where people want to self-discharge, or people don't understand what's going on and they want to leave home. So I think there was a scenario a couple of years ago, someone had a PE, needed a DOAC, but they wanted to self-discharge. So with that, it's just you explain what the condition is, explain the need for a DOAC, explain what would happen if they don't get it, why we may or may not want them to stay in hospital for that period of time. Don't be afraid to say that there is a potential risk of death if there is. And then at the end, just always check their capacity. If after all that they want to self-discharge, you can't do anything, but make sure you've explained all the risks, explain why you need them to stay, and then if they want to leave, they can leave, but just issue this as well. So if we move on, I think we have, is this an example scenario? Oh, sorry. Clear, yeah. So again, this I've already mentioned this, but make sure you've got a clear introduction, check their understanding, etc. If it's a med, just make sure you say the purpose. You don't really need to say the mechanism of action, just in a basic way. How to take it's important. If they're already on it and they don't understand, that's a common question. Just make sure you check their adherence as well, and always ice them and reassure them essentially. I think we have 2 practice scenarios. I'm not sure if we've got time for it. So we'll quickly go through the 2 example scenarios that you had a chance to practice. Let me know if you have any questions in the chat, if I can actually see the chat. But you had to explain atrial fibrillation, a DOAC. Obtaining their understanding is always quite important. Make sure you get a good enough history, but don't linger on the history too much, essentially. Sorry, the chat has just popped up for me and I can't get rid of it. There we go. So yeah, so key ideas is it's an irregular rhythm, blood pools, it's not flowing smoothly, there's a risk of clots, there's a risk of stroke. Don't be afraid to say the word stroke, don't be afraid to say the word clots essentially, but reassure them. It's not a life-threatening condition usually, but it does increase their risk of clotting and strokes and things like that. And then explaining a DOAC, just go in order, have a logical way to structure it in your head, explain the indication, tell them why they need to take it. It's not really to help the atrial fibrillation itself. You're not going to treat the condition, but you are reducing their risk of a stroke. You can explain it in words that they understand. It's kind of a blood thinner. It doesn't really thin your blood, but it reduces the blood's ability to clot essentially, so a stroke is less likely. You can mention it's a newer type of medication. It's a tablet. It's important not to miss it. You can try and say, oh, try and take it at the same time every day. The main benefit is it's not like warfarin. You don't need to have regular blood tests, but you've got a big risk of bleeding. For side effects, you'll always have the BNF in front of you for a drug counselling station, but a blood thinner or a DOAC or anything like that, just safety net them. If they've had any serious falls, if they've hit their head, they've noticed any bruising, unusual bleeding, their stools are turning black, they're coughing up blood, tell them to get urgent medical attention, A&E, call their GP urgently, or NHS 111 if they're unsure for advice. Any type of counselling, just offer some sort of leaflet or a drug counselling website, so you can send the link to them as well if you need. For the next scenario, I think it was hypertension and starting Ramipril. So Ramipril is a common one. You can also get amlodipine as a common one. Again, check their prior understanding. Explain the medical condition briefly. It doesn't have to go into too much detail, but you can mention that blood pressure it's a force of blood, isn't it, pushing against the blood vessels. You can kind of explain systole and diastole if you want, how it's the blood squeezing and relaxing. But the main thing is, with over time, if you've got high blood pressure all the time in these vessels, it's going to damage them. So even if they're not feeling any symptoms right now and they feel completely fine at this moment in time, having high blood pressure will increase their risk eventually of heart attacks, strokes. It can affect their kidneys, eyes. So make sure you mention key organs essentially. Then go on to drug. If it's a combined station, just make sure you have enough time for the drug counselling as well. explain how it works. It protects your heart, it protects your kidneys. It works essentially by relaxing your blood vessels, helps the blood pump the blood around more easily. Once a day tablet, ideally, again, take it at the same time, mainly so they don't forget. Some people, just if you wanted to, you can mention about first dose hypertension, so they can feel a bit dizzy when they first take it. So if you want to take the first dose at night, they can. It's not a break or make thing, that one. You don't have to mention it. Again, for side effects, you do have the BNF, but we all know common ones are a dry cough. So you could say it can cause this dry cough. If that does happen for you, which is rare, they can always switch you onto a different blood pressure medication. And then safety and monitoring wise, again, the BNF does mention this. So if in doubt, check the BNF. You have to check your kidney function and potassium before you start it, and then after any changes as well, just to see there's no drops in them. And then give them a bit of sick day advice as well. So if you're unwell with vomiting or diarrhea, you may be advised to pause it. Don't tell them to pause it, but a doctor may tell you to stop the medication for a little while. Has anyone got any questions based on those two before we move on to a quick run through of clinical reasoning?
Looks like we're good to keep it moving.
Perfect. So this will be a quick run through. I think I did have a slider with a quiz, but I don't think we're going to have time for that, unfortunately. Probably more unfortunate for me than you guys anyway. So with clinical reasoning, I want to do a quick thing on chest x-rays, ECGs and ABGs, but I hear you're going to have some fantastic teaching on this tomorrow, so we'll do a quick run through. Basics of chest x-ray, we know this by now. Name, date of birth, get it right, figure out who the film is for, if they've had any previous imaging, mention it. Go through RIPE, check the image quality. Most of the time in your OSCEs, it's going to be a good image quality, but just always mention it that there's no rotation, it's a good inspiration. Mention if it's an AP or PA film. Remember with PA, you've got the scapulars, it's not going to be projected within the chest. And make sure it's good exposure as well. Then ABCDE is like the typical way to run through it. People have their own ways, but if you just want a structured way, check the airway first, check the trachea is not deviated, it's not moving away or towards something. Check the lungs, just split it up into upper, middle and lower zones. Cardiac, check the heart size and borders. Remember, that's for PA for heart size. Diaphragm, check the costophrenic angles, check the hemidiaphragms, check there's no blunting of them, and then everything else, go through your bones, make sure there's no fractures, just look on the sides, check the soft tissues, check if there's anything extra, any tubes going through, any valves, any obvious pacemakers. Fine, should we do, there's like 3 examples. If people can just put in the chat anything obvious that pops up. I think I wanted people to go through it systematically, but we may not have time. So if you want to do a systematic review in the chat, or just put anything that's obvious in the chat, so we can quickly run through it.
Just pop it in the chat, guys.
If you guys want a clue, look at the diaphragms. Yeah, good, air under the diaphragm. So if we just quickly run through that, thank you so much. Yeah, so if it was a explanation station, just always mention, oh, the obvious thing I can see is I can see free air under the diaphragm, which could indicate this, but I'm going to run through it systematically so I don't miss anything. So it's an AP film. Clearly there's no data, you don't know what it is. It's slightly rotated to the left. You can see the trachea is central. You can see all the zones of the lungs. Heart doesn't look to be enlarged. You can see the hemidiaphragms clearly. You can see the costophrenic angles. They're all clearly demarcated. And there aren't any obvious soft tissues. But the main thing is you can see this free subdiaphragmatic gas, can't you? So that could indicate a large pneumoperitoneum. Sorry. The next example, I actually can't remember what the next example is. Does anyone want to tell me what they can see from this example? Or anything obvious they might see if they don't want to do a systematic review? Good. So most people have put increased opacification in the left lower zone, consolidation left lower zone. Yeah. So yeah, that's the main thing, isn't it? In the left lower zone, you can see some sort of opacification, most likely consolidation. It's PA film, it's a good centered image. You can see it's quite good penetration as well, but the main clear thing you can see is that patchy opacification essentially. Good. If we move on, oh, sorry, there's more. Yeah, everything else is normal, isn't it? Perfect. Okay, I think this one might be a bit more difficult, but can anyone see anything obvious in this one? You might have, it might be a zooming in thing, but see if we can. If not, I can point it out, but I don't think you can see my mouse.
Can you see my mouse?
Yeah, perfect. Consolidation, left lower, highlight looks funny. I see what you mean. I wouldn't say it's consolidation, but there is some sort of patchiness there. Just look more for lung markings there. Yeah, someone said left apical pneumothorax. Perfect. So if you can see the mouse, so you can see lung markings. You can't see lung markings where the mouse is essentially. So, but peripheral to that, you can see it. I do appreciate it's quite difficult to look at. Just you do have to zoom in a bit, and if this was bigger or in person, you might be able to see it better. But if we do it systematically, it's a PA film, good inspiration. The main thing is that asymmetry of the apices. So if you look at it in zones, if you start from the top, you can see that the lung edge is visible. I'm trying to use my mouse, but you can't see it at the left apex, and then there's no lung markings on the other side of that essentially, but it is visible peripheral to this. So that's why it's a left apical pneumothorax. But there's no evidence of anything else. Lungs are otherwise clear. Your heart borders are fine, and there's no blunting, and you can see the hemidiaphragm and the costophrenic angles quite well. Is that okay, guys? Yep, and there's no free air or some abnormalities. So I don't think we have any questions, but if we do, just please put them in the chat. Again, a quick run through ECGs. You're going to have teaching on this tomorrow. I think it was ABGs only, but again, just as basics, confirm the details, make sure you can see the calibrations. Usually it's already well calibrated. Check if there's an old ECG available. Usually there isn't. Main thing is run through it systematically or with a structure that you have in your head. Start with the rate, figure out what the rate is, check the rhythm. Are there P waves before every single QRS? Is your P rate upright in the leads it should be upright in? Is there a constant PR interval? Check your axis, make sure there's no deviation. I always do A1 and AVF intervals as well, then go through systematically, check your PR interval, your QRS, check your QTC. Main thing is I would look for PR and QRS just for exam stress. So make sure that your PR interval is no longer than 3 to 5 small squares, and your QRS should be less than 120. So it should be less than 3 squares. Check for right bundle branch block versus left bundle branch block if you're looking at the QRS segments. Then check your ST segments, which can be quite important for OSCEs. Make sure there's no elevation, which counts as greater than 1 millimeter or 2 in contiguous leagues. limb leads, or at least more than 2 in your chest leads. Make sure there's no depression, and the T waves as well. Make sure they're not tall tented, they're not inverted, and things like that. We've got a few ECG examples. They're just spot diagnoses. If you want to systematically review them, you can, but if you can spot the big thing in them and put them in the chat, that would be great. Yeah, perfect. First degree heart block. Good. So the rate's quite slow. So it's sinus bradycardia. You do have a P wave. However, the PR interval is quite prolonged. If you can see, it's more than 5 centimeters there, I think. I actually can't see with them. Yeah. Shall we move on? If anyone has any questions about why, just put that in the chat. I'll explain it more. This one, spot diagnosis, quite an obvious one. Came up in my A2E examination station for last year finals. So if we move through, good. There's another 2 that we can quickly go through. What do people think about this one? Focus on the T waves and check your ST segments as well, is my clue. Yeah, someone said NSTEMI. I agree. So it's an infralateral NSTEMI. So if you can see 2, 3 and AVF mainly. So 2, 3 and AVF have inverted T waves for this one. But if you look at V, which leads was it? V4 and V5, you've got some ST elevation in there as well. Is that okay? So we have one more ECG, I believe. I think this one should be quite straightforward. Sorry, I've just lost the charts. Sorry, someone said, would you please mind pointing out the inverted T waves? If we just go back to the other one, sorry. So my mouse, I don't think you can see. But if we just look at leads 2 and 3. Where's an obvious, yeah. So yeah, so the T waves inverted there. I'm trying to like point at it, but you can't see me. But mainly, I think they've said infralateral because it's 2, 3 and AVF essentially. If you see an AVF, it's more obvious. 2, you can see it as well. It's just an upside down T where it should be the other way, shouldn't it? I think it's more easy
not
to...
upside down as the P wave, if that helps.
Yeah, where the mouse is pointing essentially. Is that okay? Thank you. And then the other one, someone's already put in the answer. AF, perfect. There's no P waves, is there? And then if we move on, oh, there's one more. Oh, I forgot about this one. Does anyone want to quickly spot diagnose this one? I have to have a relook at this one. Yeah, STEMI, perfect. So you can clearly see your ST elevations, can't you, in leads V2 all the way to V6. I think you've got some in leads 1 and a little bit in AVL as well. So yeah, it's an anterolateral STEMI. I think there is supposed to be some reciprocal changes in this one as well. I think it might be 2-3 in AVF. Is that okay? So thank you for sticking with us, guys. I know it's overrun and a lot of people have left, but if heart blocks, people have spot diagnosis already. If it's first degree, fixed prolonged interval, second degree, it's just progressive until it's not conducted, or it's consistent PR interval duration with like a dropped QRS essentially, or you've got complete heart block where there's literally no association between both atria and ventricles. So this you guys can read in your own time. It's just ECG changes during MI, which I'm sure you have started revising for. This I just put in for your A to E stations essentially. It's good to just keep on top of your adult tachycardia and bradycardia as well. We just quickly run through the rest. Oh, there's a spelling mistake in there. ABG, okay, so there are a few examples that we can go through. Main thing is, again, you're going to have some great teaching on this tomorrow, but just make sure, check the patient's not hypoxic, check what they're on, make sure they're not on oxygen and it's less than what it should be, check if it's type 1 versus type 2 rest failure, are they acidotic, alkalotic. I doubt you're going to have time to calculate an anion gap. Main thing is acidotic, alkalotic, is it respiratory, is it alkalosis? Does anyone want to spot diagnose the next example? So it's a 68-year-old male with COPD, worsening shortness of breath. You've got your ideal values next to the actual values. So just either tell me, is it type 1, type 2 failure, and is it, oh, someone's put something. Perfect. Respiratory acidosis. Someone's put with partial metabolic compensation and then type 2 rest failure. Perfect. Yeah, it's type 2 respiratory failure. The bicarb is raised despite the acidosis. So it's probably an acute on chronic picture essentially, but I would agree with everyone there. Perfect. If we move on quickly, sorry, it's a quick run through. I'm not explaining everything quickly. This one, anyone got any ideas? So it's a 19-year-old female presenting with feeling lightheaded. She's quite nervous about a job interview, apparently. And can someone think of some differentials as well? Or the main, yeah, perfect, alkalosis. I think the key there is she's nervous about something, isn't she? So it's, yeah, perfect, anxiety. So it's most likely anxiety, hyperventilation. You do have to rule out other things. If it's persistent tachycardia, then rule out P's and things like that, but hyperventilation is most likely. The third example. Oh, I've not even put a little scenario for this. Just go for it. We have got metabolic alkalosis. Perfect. And there is no respiratory compensation in this one. Metabolic alkalosis can be a few things, like persistent vomiting, for example, diuretic use, any type of big transfusions, something like that. but there's loads of differentials for it if you ever get asked. And is there one more example? 27-year-old male presents with asthma. So this is their initial ABG on 15 litres of oxygen. So the oxygen levels are quite bad if you factor in the fact that this should be on 15 litres of oxygen. And if we look at the second part, I think there's a second part to this as well. So if you look at this scenario, how would you class their asthma essentially? Or at least after the initial treatment anyway. Good. Yep. So you put metabolic and resparculosis. Yeah. Okay. Life-threatening. Yeah. So the main thing here is you can see that the CO2 is starting to become normal, isn't it? So that is classed as life-threatening because they're starting to get exhausted or tired, which means, yeah, that would be classed as life-threatening. Initially, yeah, resparculosis. That's fine. Perfect. So this is just, I added a bit on ethics and law, but we've already talked about this. DVLA rules, you can mention it in your counselling stations. Make sure you're aware of some of the rules. If you don't know, just say, oh, we will have to check with DVLA, but there do tend to be stricter guidelines with, for example, group 2 lorries and buses, and with group 1s as well. Just make sure you know how long somebody can't drive for. So for example, if you're getting blackouts, if it's an explained cause, they should be able to drive straight away. If it's an unexplained cause, you might not be able to drive for 6 months, for example. After seizures, if it's the first seizure, you can't drive after 6 months either. Pacemaker insertion, I had to search this up myself, but group 1, no driving for 1 week, which is cars and motorcycles. Group 2, you can't actually drive for 6 weeks. And if you have a ICD inserted, I believe group 2s are banned from driving. So yeah, so it's a permanent ban, and then MI, uncomplicated, group 1s can drive after a week, but they shouldn't drive in the first week, but their license won't be taken off them. Make sure you're roughly aware of DVLA rules essentially, but it's not a thing that you should sit and memorize. Yep, I don't think we have time for prescribing station. These are two very easy examples. It's just sensitivity and, again, prescriber DOAC I put in.
Shall we stop sharing and then I can just share the slides and people can have a go at these in their own time so we don't go through them now?
Perfect. Thank you so much, guys, for entertaining us this late. We ran quite a lot over, but thank you so much.
That's also on me though. Like, I started it right on the time and we didn't have slides. And
there were quite a few slides as well, so that's on me.
Yeah, it's okay. We'll learn, we'll adapt, guys. Please fill in feedback and help us do that. It's our first time ever running a finals like OSCE revision thing, so we're really receptive to feedback and making it better. So thank you so much all for coming.